Hi, good evening, everyone. I welcome all the doctors across the country for today's webinar. This webinar has a very interesting topic, which is the pediatric migraine, and we have a very eminent doctor to talk about this. As we know, the topic is the concepts and controversies. I would request Dr. Kenny to introduce Dr. Kunju and welcome him for the presentation also. Over to you, Dr. Kenny.
Thank you. I'm Dr. Mukundraj Kenny. I'm medical advisor for Johnson & Johnson based at Mumbai. I welcome you once again for the program. It is my pleasure to introduce the speaker for today's migraine session, Professor Dr. P.A. Mohammad Kunju. He is the ex-professor and head Department of Pediatric Neurology, Government Medical College, Trivandrum, Kerala. He has completed his MD in Pediatrics and DM in Neurology from GMC Trivandrum and has been practicing since last 30 years as a pediatric neurologist. He completed his WHO fellowship in pediatric neurology from Pittsburgh, USA in 1996. He developed the first ever pediatric neurology department in the whole of India. He has been the president of Indian Association of Pediatrics Kerala in 2018 and president of Kerala Association of Neurologists in 2018 and 19. He is the founder editor of the journal Indian Journal of Pediatric Neurology. He has to his credit around 60 research publications, 6 books as an editor, and he has contributed to around 11 books in the pediatric and neurology segment as a editor. He has organized more than 20 conferences, workshops, and he has presented more than 100 papers as well as CMEs across various conferences across India and other parts of the world. We welcome you, sir, for today's session on pediatric migraine and would request you to take over the session.
Okay, thank you. Thank you for the nice introduction. And I will start sharing my slide. Hope all of you can see it now and you can hear also. Okay, so now first of all, I must thank Johnson & Johnson for organizing this meet of pediatric migraine, because headache in children is not that being recognized by all, and people have an idea that pediatric headache or children does not get headache, but we all know that headache in children and due that to migraine is very common, and it affects their day-to-day life. And because of the commonness and it affects the activities of a child, the understanding, evaluation, and treatment of headache and primary headache, that is commonest one, migraine, is very, very important. So in this, I'll show that a child who presented with acute onset of headache. She had a frontal headache accompanied by photophobia and phonophobia. The frontal headaches were worse in the morning and with position changes, but did not awaken her from sleep. No visual auras or prodrome, no sensory motor changes, no diplopia, no visual field defects. For the most part, the neurologic examination was unremarkable. Ophthalmologic examination showed papilledema bilaterally. So a visual field examination showed no enlargement of visual blind spot or no visual field abnormalities. Her weight was 47 kg. That means she was a bit overweight. So thyroid function testing was also done at that day. Since she didn't have any other neurological finding, an orbital ultrasound was done, which showed an optic nerve swelling. that gave us a clue. And all of you know that evaluation of papilledema definitely requires a CT scan or MRI. And in this case, an MRI was normal because MRI is done to rule out brain tumor, whenever there is papilledema, or we have to look for sinus thrombosis, hydrocephalus, or even optic masses. But since the MRI was normal and there were no neurological finding, we thought of a benign intracranial hypertension or idiopathic intracranial hypertension. So she was put on acetazolamide 10 milligram per kg per day, and a lumbar puncture was done. So her headache resolved immediately after the lumbar puncture. And the CSF study was negative for bacteria or tubercular culture. So that means the child had seizures, the headache without any neurological finding. And so this is a case of pseudotumor cerebral idiopathic hypertension. And usually the treatment in children also, because the child had obesity, a weight loss regime was given, and a serial LP is usually required when there is no improvement in headache. Up to 20 to 40 ml of CSF can be drained. And some situations we may use prednisolone also. And in this child, we especially when there is a history of no responsiveness to Diamox, we can go for topiramate, another drug which has a carbonic anhydrase inhibition mechanism, and that also can produce weight loss also. And some children shunting also will be required. And in this case, you can see that at that time the thyroid result came after 1 week only, and she had hypothyroidism. So we know that a child with obesity, hypothyroidism is prone to have a pseudotumor cerebri. But later, she had, after 2 weeks, the mother noticed an unusual smile. That was she developed a left-sided Bell's palsy. Because whenever there is a Bell's palsy without, again, in this case, even though there was a headache and papilledema, but it was a low motor neuron type of facial palsy. Her blood pressure was monitored and it showed a high BP. In number of cases, we have seen Bell's palsy associated with high blood pressure in children. So we have started her on atenolol, and her BP came down. But again, here her story does not end, because she developed a headache which was persisting, and it is coming in a recurrent manner. It is so characteristic of migraine, and she had a typical fortification spectra with a scintillating scotoma. So that means this time we made a diagnosis of migraine also. So that means finally this child was getting treatment for hypothyroidism, high BP, and migraine. This is the case actually we have seen 12 years back. And this child even now come to me for migraine prophylaxis and revision. So 3 points I just wanted to highlight from this case. One, as I am showing this picture, always don't forget to take BP even in a small child. Second, migraine also may be a coexisting disease with an idiopathic intracranial hypertension, especially those patients who have been treated for pseudotumor cerebri later can present with migraine. And there are a lot of case reports and even a series of late Dr. Matthews has reported a series of migraine patients with idiopathic intracranial hypertension. So for comprehensive understanding of migraine and headache in children, I usually describe them in EC3s, because this EC3 we can include headache understanding of the headache types, a comprehensive evaluation, and the treatment modalities. So these EC3s, by which I think this slide summarizes the complete talk, there are 3 types of headaches has to be understood. They are the primary headache, secondary headache, and certain facial pain syndromes. And among this primary headache, there can be 3 types. They are the migraine, tension type of headache, and cluster headache or trigeminal autonomic phalangias. And among the when we consider the primary headache, 3 modalities of treatments are available, whereby we'll give acute treatment, preventive treatment, and biobehavioral treatment. In the 3 modalities of treatment also, I think we have 3 types of drugs or 3 types of methods of treatment. For example, in acute treatment, drugs like non-steroid anti-inflammatory drugs, antiemetics per se, and triptans. These are the 3 modalities of acute treatment for migraine. And similarly, the prophylaxis or a chronic treatment also, we have 3 modalities. They are propranolol, so antidepressants, amitriptyline, topiramate, and biobehavioral therapy. So this summarizes this EC3 summarizes the migraine in children as well as in adults. So, but the only thing is that in children, many times we may not identify facial pain syndromes like trigeminal neuralgia or post-herpetic neuralgia. Similarly, cluster headache or trigeminal autonomic cephalalgia is also very uncommon in young children, but in adolescents as well as in young adults, this will be a manifestation. Then coming to the problems in understanding migraine, we all know that there is a difficulty in diagnosing migraine in children because of the headache duration, which is less prolonged, more likely to be bilateral, difficulty in describing the headache features and associated symptoms by the children. Most often, they will not be able to describe even the headache in a proper manner. And evolution of the semiology, because initially there may be presenting as a behavioral changes or some sort of day activity changes, etc. only. But only thing is that those of you are managing migraine in adults also will know that these difficulties are not confined to the pediatric population alone, because a study comparing physician diagnosis with ICSD, that is the International Headache Classification, 4 to 72 hour duration was seen only in 61.9%, but when 1 to 72 hour duration was taken, 71.9% met criteria. Similarly, in adult bilaterality and other features such as difficulty thinking, lightheadedness, fatigue, all these also may be seen. That means atypical manifestations can occur in adults and children, but children, it is a major manifestations. And coming to the headache type classification, because we know that in all, we have to identify whether it's a primary headache or a secondary headache, because that is the first step. And among that, usually the secondary headache would be due to a traction or inflammatory headaches like tumor, meningitis, subarachnoid hemorrhage. These are the 3 important conditions. But we must understand that in children as well as in adults, primary headache constitutes 90% of the headache. That means only 10% is secondary headache. But our aim is to always identify the secondary headache. So in order to identify this secondary headache or to identify the focal abnormalities by which you can identify a underlying problem, a comprehensive headache evaluation in office practice as well as in a pediatric practice, it may not be possible to examine a child in a complete neurological manner, because starting from higher mental function to cranial nerve, motor system, sensory system, cerebellar sign like that. So, but we can do a quick neurological examination, starting from the observation of the child, as in this case, because child is in the hospital bed, because a child who is admitted itself shows that it must be a severe headache with some underlying problem. And again, so history will help you in identifying the type of headache, whether it's an acute, chronic, or a recent change in headache character, etc. And many times children themselves will come out with drawings. This drawing, actually, the first time when the child came to me, she, a girl child of around 12 years, she brought this type of drawing, and you can see that she has even drawn a bar diagram to demonstrate her headache during that time. And again, see how she was feeling that headache. And even she has expressed her feeling in Hindi as well as in English also. That means description as well as the drawing by a child will be very much helpful in understanding the headache pattern as well as the characteristics. Among them, the warning signs has to be looked into, and easily you will be looking for a neurological disturbances. But again, very typical hemiplegia or a monoplegia may not be there, just a clumsiness or a mild difficulty in writing. Because I had a child a patient who had a very subtle difficulty during her SSLC examination. And when she came, I found that she was having a mild deafness as well as a mild deviation of face. So she was a case of CP angle tumor. So that means this sort of evaluation is very, very important. And then cognitive dysfunction or a decrease in school performance is other warning signs. Then, as I have mentioned, a change in pain character and pain occurring always on one side. If it is coming only on one side and not shifting to the other side, that means something abnormal on that side. So these are some of the warning signs if it is there. So our aim must be that when headache is present, you look for any warning signs. If warning sign is not present, means it is a primary headache. But if warning sign is present, definitely it is a secondary headache. Even in primary headache, you may have to look for atypical features or red flag signs. When such findings are also there, as well as if you think that is a secondary headache, then you have to do a complete neurological examination and then go for investigation. Again, a complete neurological examination, as I mentioned, you don't have to go for a complete evaluation. See, most important thing is to examine the eyes. As in this case, you can see that there is a squint and lateral rectus palsy. So this again may be an indicator for a localizing sign. Also, even in a case of us, ending will be there. And then in children also we can do a visual field testing. Visual field testing, again, you don't have to do the confrontation method as being described, taught to us from our undergraduate time, and we don't have time also. But in children, only one thing that you have to do is just make the child sit in front of you and keep your hands on the sides and just wiggle your hand and ask whether the child is seeing both the fingers. If child is able to see both the fingers, means she has her there is no bitemporal hemianopia. But if he's not seeing one side or the both sides, means there is bitemporal hemianopia, and that is the commonest visual field defect in a child. If she is having this abnormality, then you can go for a full visual field testing. And most important condition which can present with headache and bitemporal hemianopia is cellular tumors like craniopharyngioma or a pituitary tumor. These are some of the common conditions, the visual field defect in children. And then if possible, you have to do a fundus examination. And if fundus examination is there, again, don't frighten the parents by saying that it is a spaceoccupied lesion. But as in our first case, it may be a benign intracranial hypertension also. So we may do a MRI to rule out tumor. And if it is there, then it has to be managed like that. And another important confusion may be with sinusitis, because many people, when we see a child with headache, we ask the parent, "Are you having a headache?" Then again they will tell, or a mother will tell, "So I am having sinus headache for long." But again, you must all know that a sinus headache without discharge, without sinus tenderness, will not be producing a migraine or a headache symptom, because sinusitis will produce sinus tenderness, not our sinus pain, and with discharges. So if otherwise, typical frontal or a temporal headache may not be produced by sinusitis. And one sign will be very useful in children also, because that is the Muller sign to assess for sinus tenderness. You pinch the nose, then ask the patient to blow out. That means a Valsalva maneuver-like thing for 5 seconds, then cough. So this will produce a positive pressure in sinus, followed by rapid decompression. So this will produce pain over the involved sinus, and it is a very good sign for diagnosing sinusitis. And again, International Headache Society gives criteria for making a sinus diagnosis of sinus headache. That means that you must be demonstrating discharges as well as sinus collection either by X-ray or by MRI. So that means if these things are there, then you can make a diagnosis of sinusitis. Then coming to a quick neurological examination, again in a child, you may not be able to test the power, tone, etc. By taking more time. So when the child is sitting or standing, ask her to outstretch the hand. As in this case, you can see that there is a hand drift, and that means there is a focal neurological deficit. So that will give you a clue of a focal deficit. And similarly, in the sitting position itself, you can ask the child to bend the neck, and this bending itself may produce a wincing. That may be an evidence of a neck rigidity. And sometimes, see in this case, you can see that only mild neck rigidity or wincing, but she had the same child. The same child had a severe exudates, and she was a case of a tuberculous meningitis. So this sort of examination will give you a clue. But in certain situations, already the child may be having a primary problem like this. In this case, you can see there is a hydrocephalus, and they come with a headache. As I have told you, children with even a problem like this can have a migrainous type of headache or a tension type of headache as an associate. So it may be difficult for you to differentiate whether it is primarily due to this hydrocephalus. You can see that this hydrocephalus is shunted, and you see the shunt here. So when the child came with headache and vomiting, we consulted the neurosurgeon, and they were telling that because the shunt is functioning, but because the child was having severe headache and vomiting, I took an X-ray, and here you can see that by a simple X-ray, I was able to demonstrate a break in the shunt tube, and this is a normal shunt tube without any breakage. So by these simple measures, you may be able to identify the underlying abnormality. And again, a quick palpation over the head, because in this case, this child was having a recurrent headache, occasional vomiting for a long time, and because of that, child was diagnosed to have a migraine. But a small palpation over the temporal region, I found that there is a swelling. Swelling means some bulge in this region, and so you can see that the CT scan showed an arachnoid cyst there. And again, you can appreciate that temporal swelling in that CT scan. So that means this was acting was having a ball valve phenomena, and episodic headache was occurring. So again, a small examination has revealed the finding. This is another child with almost similar finding. See here. Actually, this child was diagnosed as having a brain abscess initially, then only we confirmed that it was only a case of arachnoid cyst. So you have done an examination, clinical examination, and you have found that no focal neurological deficit, there are no warning signs, and no red flags. Then it is only headache, means it is a primary headache. So if it is a primary headache, our aim must be to identify the headache type. And I must say that among the neurological disorders, again, actually International Headache Society itself is claiming in their third edition of International Headache classification that headache is the only disease group where you can get a definite criteria for a diagnosis. Each and every syndrome is defined. And I am happy that I have grown up from 1988, from the World Congress of Neurology, when the first edition of this classification system has come. And I got this cephalalgia copy from World Congress of Neurology in 1989 in New Delhi. At that time, I was doing my DM neurology. And exactly after 30 years, that means in 2018, they have come up with the final third version of the International Headache Society classification. Though they have released the ICSD-3 beta in 2013, it took 18 years for field testing, and they wanted to compile the ICD classification also. And IHS site is giving a good description of all these the headache entities, and there we can find diagnostic criteria. And for migraine, here again, my EC3s I have applied here also, because migraine criteria that is taken from the IHS criteria, it is most important criteria for them is unilateral. Second is pulsating in character, and third, the pain severity is moderate to severe in intensity. These are the three primary characteristics of a migraine headache. And then, in addition to that, we have other clinical criteria which I'll be coming. But we must understand that among those three features I have shown, two may not be seen in a child because frequently the headache may be bilateral. And other symptoms, periodic symptoms, are often because of migraine, like vomiting, vertigo, abdominal migraine. And occipital headache, which is described in typical migraine, can be a problem. For example, a posterior fossa tumor, which is one of the commonest cause of tumors in children, may also present with the occipital headache. So migraine, it is typically it is unilateral, hemicrania, temporal. Sometimes it may start from the occipital and spread anteriorly. We all know that tension type of headache has got a band like a tightening sensation, or it may come from the vertex, or a vertex headache like this. And cluster headache will have associated trigeminal autonomic manifestation, as you can see here, pain around the eyes, watering, that means rhinorrhea, as well as watering from the eyes. So the criteria for making a diagnosis of migraine as well as tension type of headache to be understood. I think neurologists, all neurologists will be aware of it, but for those other people, physicians as well as pediatricians who are attending, these are the definitive criteria, because I have, when I talk to them, I understand that many are not aware of this clinical criteria. For every headache, they make a diagnosis of migraine. So you just remember that, as I have mentioned, those three characters, they are the unilateral, pulsating, moderate or severe intensity can be utilized. Okay. Then coming to the other criteria, because headache, more than 5 attacks lasting for 4 to 72 hours is the criteria in adults. And aggravation by routine physical activity. This is another important criteria for making a diagnosis of migraine. And then other criteria is that it's more than 2 of the following. It's either unilateral, pulsating, moderate or severe intensity, and aggravation by routine physical activity. And one of the following was nausea and or vomiting, photophobia and phonophobia. And whenever we make a diagnosis of migraine, that means, as we have learned, it is primary headache. So you have to exclude all other secondary causes before making a diagnosis of migraine. And in tension type of headache, I have just compared with the migraine criteria. They are because you can see here that tension type of headache lasts for 30 minutes to 7 days. That means it can last for even a week, like that, on a daily basis. And it is usually bilateral, non-pulsating in character. And again, tension type of headache usually is mild to moderate, not severe. Because of that, it won't affect the routine physical activity. They'll be continuing their activity, but will be complaining of headache, unlike a migrainous patient. And usually nausea or vomiting will not be there, but for either one or either the photophobia or phonophobia may be present. So these are the clinical criteria for making a diagnosis of migraine as well as tension type of headache. That means in tension type of headache, duration can be short, like 30 minutes, but it may last for days. The criteria that is utilized in children, adult is 4 to 72 hours, but in children, it may last even less than 30 minutes, or even usual criteria is 2 hours. Okay. And it may be bilateral, either a frontal or temporal. And the duration, that means you can see that duration may last 2 to 72 hours, unlike 4 to 72 hours in adults. And we all know that there are certain genetic predisposition for certain migraine syndromes. 70% of pediatric patients with migraine have a family history of migraine headache. And among them, familial hemiplegic migraine type 1 may be associated with the calcium channel gene, and FHM2, that is familial hemiplegic migraine with the 2, you can remember that ATP is ATP1A2 gene, and FHM3 is associated with the sodium channel gene. So FHM1, CACNA1A gene, FHM2, ATPase gene, ATP1A2, and FHM3 with the SCN1A gene. So, and again, you must understand that most of the genes may be associated with the paroxysmal torticollis also, because recently it is found that many of the children who are having a typical paroxysmal torticollis of infancy may have one of these gene association. And I won't be going to the details of a pathophysiology of migraine because it will take long time. But only one point that we can understand that again here I have identified the 3 important factors to be learned in the pathophysiology of migraine. So that means there is a neuroanatomical correlate because there is a structures destined to generate pain for migraine, and when they are activated, they produce pain. And again, everybody will not get it with this pain, even though all of us are having a trigeminal-vascular system. But for that, vulnerability for migraine should be there. For that, there are certain triggering factors as well as an intrinsic factors, genetic factors will be there. And some genes, and as I told you, genetic factors, biochemical factors will be involved in the generation of the headache. So manipulation of these things, these 3 things, will be able to manage the headache. So that means the neuroanatomical correlates, we all know about the pain sensitive structures, but for the migraine genesis, it is the large intracranial vessels and dura mater and the peripheral terminals of the trigeminal nerve that innervate it. That is the trigeminal-vascular system is considered as the pain neuroanatomical correlate of migraine. And then coming to the actual generation of the headache, we have the 2 other anatomical parts, that is the ventro-posterior part of the thalamus and certain part of the cortex, and again the caudal part of the trigeminal nucleus, which is extending to the dorsal horns of the cervical spinal cord, trigemino-cervical complex or the trigeminocaudalis nucleus. Then also the periaqueductal gray matter. These are also important in the part of the neurovascular system. And vulnerability, again, you must understand that vulnerability to migraine is inherited, and we can call that such person will be having a migrainous brain. And when there is a triggers, this pain will be generated. And the migraine is one type of headache where without any injury you can get pain, because all other pain usually there'll be an injury, inflammation, and then you get a pain. But here, without any injury, but there is a sort of an inflammation is taking place and a headache is generated. For that certain triggering factor, this is in one of our studies where we have compared the propranolol versus topiramate. We identified the triggering factors. We can see that in children, there were deprivation, loud noise, bright light, eye strain, watching TV, reading, exercise, playing, traveling, etc. were considered, because all of us know that many will be having these triggers. And these triggers, we know this, as we have mentioned, the susceptibility to migraine is hereditary, and threshold of the susceptibility lead to a neuronal hyperexcitability, because this threshold varies in different person differently, and again depending upon the situations, and that will lead to a spontaneous depolarization. And this tendency for spontaneous depolarization may be by a deficit in the mitochondrial oxidative phosphorylation, an alteration in the neuronal voltage-gated calcium channel function, and an intracellular magnesium deficiency, because nowadays we are finding a role for magnesium in the management of headache also. And when we are describing the migraine with aura, we definitely know the pathogenesis, because here a spreading depression of Leo, that is a spreading wave of depression starting from the occipital cortex. It spreads anteriorly. So this, we know that because it starts and spreads in 1 to 2 millimeter per second, you can see that there will be a generation of migraine aura. Initially starts with an visual aura because there is involvement of the occipital cortex. Then when it reaches the parietal cortex, you can see that the paresthesia, numbness, etc. And very rarely when it spreads anteriorly, you may get the hemiplegic migraine. So this is the spreading depression of Leo. That means migraine aura as well as headache can be considered as a neuronal phenomena. It is evoked by aberrant firing of the neurons and related cellular elements, characteristic of cortical spreading depression, not evoked by ischemia. Muscular changes follow the changes in the neuronal activity. And this will lead to a local inflammation. That is where the scalp swelling, allodynia, etc. happens. And when it comes to migraine without aura, this is also given in the IHS criteria summary. There are no changes suggestive of cortical spreading depression is described. But again, as we have mentioned, migraine is neuronal. So glial waves or other cortical phenomena may be involved in migraine without aura. And messenger molecules in nitric oxide, 5-hydroxytryptamine, and calcitonin gene-related peptides are also involved in the generation of migraine without aura. So now I will go to another case report. These were two children, 4-year-old Somu and 2-year-old Meenu. Both were siblings and both had this similar history. But 2-year-old Meenu was playing and she suddenly ran to the mother and hugged her. During one such attack, mother noticed to and fro eye movement, and usually she used to vomit and went into sleep. Because of this phenomena, somebody has made a diagnosis of vertiginous epilepsy, and she was put on carbamazepine, but without any improvement. But we know that this sort of history, that means a child who is playing suddenly run towards the mother, hugs her because the child is feeling wobbly. That is why she goes and hugs the mother, because she is afraid that the child will fall. And if the mother is observant, they can see this nystagmus, that is the to and fro movement, eye movement. And many children will be vomiting, and most of them will not sleep, but sometimes they may sleep also. So that is why it is not a seizure phenomena, but it is benign paroxysmal vertigo of child, because most of the time children may not complain of vertigo. And her mother had a history of migraine. And the drug which I gave for treating this one was, when there is a recurrent attack, you can give a dimenhydrinate. And so this is benign paroxysmal vertigo associated with episodic ataxia, nystagmus, and which lasts for seconds to minutes. Consciousness and ability to verbalize will be retained. That is the most important point. And usually these children will have an associated motion sickness. Migraine headache may occur several years later. So the dosage of dimenhydrinate, because tablet is available as 50 milligram tablets, and you can give 5 milligram per kg per 24 hours if the attacks are severe or lasting for a long time. And another, so this is the periodic syndromes that occurs in children, or the migraine variants that occurs in children. But nowadays it can described in adults also. So the migraine variants occurring in children, that terminology they have taken away, and it is considered as just periodic syndromes associated with migraine. And another characteristic syndrome that may occur in children, and many times pediatricians will be referring them to the neurologist, is cyclical vomiting after a lot of investigation. So again, paroxysmal gastrointestinal dysfunction associated with, some days they may get a headache in some episodes of vomiting. So there will be recurrent episodes of intense vomiting, at least 4 times per hour, separated by symptom-free intervals, with attacks occurring at least 1 week apart. And symptoms usually have a rapid onset, and episode usually lasts for 6 to 48 hours. So that means many times child may have to be admitted in the hospital also. And recently there are some reports that the infantile colic may be linked to childhood migraine. So that means the migraine can start in the early infancy also. And another periodic manifestation or a migraine variant in child is here. You can see that this child was getting episodic head tick associated with pallor, agitation, and vomiting. And this is what is called as paroxysmal torticollis of infancy. There are repeated episodes of head tilting associated with nausea, vomiting, headache lasting for hours to days. But in an young infant or an young child, paroxysmal torticollis of infancy, but don't forget to make the child walk, because some children may be having ataxia secondary to a posterior fossa tumor. As you can see in this child was getting episodic torticollis, but again, look at the child. She feels so sick and she was reluctant to walk also. And her MRI showed, you can see there again a tumor that is coming from the posterior fossa, a large tumor. So don't just make a diagnosis of paroxysmal torticollis. You have to examine the child, look for other neurological signs. And another paroxysmal phenomena that may occur in a child as well as adult, especially females, are abdominal migraine. Paroxysmal episodes of intense acute periumbilical, midline, or diffuse abdominal pain lasting 1 hour or more. Episodes are separated by weeks to months. The pain is incapacitating and interferes with normal activities, stereotypical pattern and symptoms in the individual patient. Here again, I have found that they will be having a associated headache also if you ask carefully. And another condition which may be confused is confusional migraine, because again, common in younger children, never seen in post-pubertal adolescence, because the child has a period of confusion, disorientation with or without agitation, followed by vomiting, so which is relieved by sleep. So such a phenomena occurs. Again, you can you must make a diagnosis of migraine, and you can use the terminology acute confusional migraine. And now I will go to another case scenario where again many times the pediatricians or even the neurologists also may not be making an accurate diagnosis, because here again definite history is very, very important. A 13-year-old Aminat, name is changed. Pediatrician's referral letter, a nice description of a seizure, appalling, stiffening, tonic-clonic movement, 2 times with a 6 months interval. So she was put on carbamazepine. Because she had repeated attacks, she was referred to a neurologist, and he also gave a reply, EEG normal, but he increased the dose, giving a note. I do not doubt that she has an epileptic tendency, and I am sure that she must be on AED for at least 2 years free from attack. But because they were not convinced with the diagnosis and they were not happy to continue with the anticonvulsants, they came to me. And when I asked history to the child, because most of the time we forget to ask the child, what did you have? Or what symptoms you had. So that you have to ask. And child said that because a feeling of something coming up from my tummy before I forgot everything. A blurring, giddy, and then slumped down. Mother many times tried to keep her up. Then stiffening, shivering of arm also has occurred. So we must ask, what has happened? What has happened before that so-called seizure? Because here the attacks are very much suggestive of a seizure. So what has happened before the seizure? Then we can the history came. She had severe abdominal pain and unilateral headache. So this has happened, and after that only she went into a state of unconsciousness. So previous time also she had a headache as well as diplopia also. That means she had a diplopia also in the previous attack. So definitely it was a case of migraine. Probably it would have been a migraine, that means a migraine with a brainstem aura because of the diplopia. And in such children, because a migraine with syncope, especially in adolescent girls, is a very common association, because I must say that it is common and not uncommon. And some may even have reflux anoxic seizures also because of the vagally mediated cardio inhibition. So that means an abdominal migraine with an unconscious happening with a migraine with syncope or a basal, the migraine with a brainstem aura presenting with the syncope is not a rare entity in children. So having understood the criteria, primary, secondary headache, I just go through the treatment of migraine in a child, starting with the, again, as we have mentioned, our EC3s, because we have mentioned that for treatment also, acute therapy is there, the preventive treatment is there, and then biobehavioral therapy. In the acute therapy, we can use non-steroidal anti-inflammatory drugs, triptans, and antiemetics like dopamine antagonists, and many times we'll be combining these modalities of treatment also. Among these non-steroidal anti-inflammatory drugs, paracetamol, ibuprofen, and I find naproxen, because many times when I get the patient, already they have tried paracetamol from a pediatrician. So usually naproxen is my drug of choice. And triptans also may be required in certain situations, especially in children above the age of 6 years. Sumatriptan, rizatriptan, solmitriptan, etc. is there. And for dopamine antagonists, we can utilize prochlorperazine, metoclopramide, or domperidone. Okay. So for managing a headache, classically a stepped care approach was described earlier, where depending upon the onset, because we start with paracetamol, then go for diclofenac, triptans combination like that. But we all know that nowadays it is not that much, because patients know, usually they know what to do. And many times by trial and error, this, especially in adult as well as in older children, by the time they come to you, they know a cure about it, and when do they require a treatment. So that approach we can also utilize. So, but definitely we have to go for a migraine diagnosis by utilizing the IHS criteria. Then you have to assess the disability, because a disabling headache definitely requires acute treatment as well as a prophylactic treatment depending upon the recurrences. So for assessing the disability, you have to do a PEDI-MIDAS, because a MIDAS in adult and pediatric MIDAS, migraine disability assessment scale in children. Then you, after the assessment, patient communication education is very, very important, because otherwise there are a lot of misunderstanding about the headache, and most of the time children will be very much afraid of their headache, and they will be afraid that they are going to, because their colleagues, their friends will tell them that they are having a very big tumor inside their brain. So many times I teach them, and if when there is some evidence for some indication for scanning, or if they bring a scan, most of the time nowadays people come with a scan itself. So I just show the scan to the child and tell him these are the brain or eyes or brain, and both sides are looking same, and here there is white, that whiteness is in the other side, like that. So that patient education, and tell him that we are not seeing anything additional, that means no tumor or anything. So an MRI and a description itself will cool their nerves, and the headache will come out. So once we have assessed it, an individualist management is thought, that we assess attack severity, degree of ability, how is more important, and you look for other some days that will be more, and preference, prior response, as I have mentioned, and the coexistence conditions are very important. And we go for a stratification, that is a stratified approach. We call it a stratified rather than the step approach for the pain management of WHO. The current tendency to stratified approach. So we must be going for a treatment as determined by the severity and as discussed with the patient. And one point you should always remember, that medication overuse also can lead to headache. So that also must be remembered. So that means you have stratified, with the stratified care approach, we did a diagnosis, and you have assessed the severity by MIDAS, and then to identify there is a low need for treatment or need moderate or high. So depending upon so the situation, same child may require a high need at some time or he may be at low need level. Depending upon their severity, know what to do. So that means they can go for a non-steroidal inflammatory drug, or they may go for a triptan combination, depending upon that. The stratification is very, very important. So acute therapy, as I mentioned, in addition to the non-steroidal anti-inflammatory drug I mentioned, I have found that severe cases ketorolac injection or a ketorolac. One similarly, there are certain indomethacin sensitive headaches, exercise-induced headache, or the cough headache, etc. Definitely respond to indomethacin. And then tramadol may be useful, especially tramadol with paracetamol combination. Again, even the ultra variety or semi variety also be used because where a combination of paracetamol with tramadol can be used. And in some situations, especially when that is migraine causes, dexamethasone also may be used, especially when the headache is persisting for more than 24 hours. And as we have mentioned, in the EC3, the another armamentarium for the acute treatment is antiemetics. Don't forget that, because metoclopramide, domperidone, etc., will have its own role in the management of headache. So, and sometimes see prochlorperazine 5 milligram mouth dissolving tablets are available. This can be utilized. Similarly, promethazine and combination or using separately metoclopramide or domperidone. This is again very, very useful. So these are some of the acute therapy that I have mentioned. Ketorolac, those who are having difficulty in managing, then we can go for indomethacin. And don't go for dexamethasone, because what I have found is because when the headache is persisting, if you indulge in dexamethasone initially itself, you may end up missing a severe underlying problem. For example, you may miss a tuberculous meningitis. So don't jump into that just only after excluding all other entities. And certain situations we can use triptans like sumatriptan, naratriptans, etc. And these are again approved for use in children above the age of 6 years. So these are some of the triptans. They are 5-HT1B receptor agonists. So you can see here. And then we'll go for the next level of treatment, that is our prophylactic treatment. Here again, 3 modalities we have mentioned: beta blockers, calcium channel blockers, and anti-epileptic drugs. So here, prophylaxis in children is also given when the migraine attacks that are prolonged and headaches attacks are frequent. That means more than 2 severe attacks per month, or incapacitating, not relieved by symptomatic treatment, critical times such as during examination, a trial of the drug for 6 to 12 weeks. That means 3 months may be sufficient. And nowadays, I prefer Flunaris in children, and because it is recommended also. And the dosage you can remember as just 0.1 to 0.3 milligram. Again, you don't have to remember the milligram per kg. 5 milligram tablets are available. Young children, I start with 1/4 tablet, and older children you start with half tablet. And many times I have found that you give twice daily rather than once daily, because the practice among what I have seen in ENT specialists and other specialists, and among ourselves, also many neurologists are also using as a single daily dosage. But what I have found is that when you use it as a twice daily dosage, it acts well. Because when a child comes to me, started flunarizine from somewhere else with the once daily, same drug, same dose, I will make it twice daily, and they do well. So that means twice daily dosage is better. And then only thing is that body weight gain, drowsiness, and some children may be feeling a tightness of the chest also. And older person, remember that flunarizine can induce Parkinsonism. So you must be very, very careful, especially when you are starting flunarizine in persons above the age of 35 years. And we have done a number of studies in headache in children. And among them, two important studies are one is flunarizine versus sodium valproate in the prophylaxis of chronic headache syndromes in children. That was done in 2007. And we have found that frequency after the treatment by both the flunarizine and sodium valproate both had a very good improvement, because we can see that before treatment, monthly frequency headache was 10.92 times in the flunarizine group and 10.33 times in the sodium valproate group. But after the treatment, it has come down to 2 and 1. So remarkable improvement after the flunarizine as well as sodium valproate. Similarly, the duration of the headache also has come down. And you can see the disability, because before treatment, actually the disability, the Pedia disability, grade 3 and grade 4 were only recruited for treatment, and they actually converted. You can see that grade 1 and grade 2, and grade 3 and grade 3 were grade 3 and grade 4 were only negligible. So definitely remarkable improvement after flunarizine or sodium. And you can see that both of them are having almost equal efficacy in management of migraine in children. Similarly, topiramate is now approved by the US Food and Drug FDA for usage in migraine also, and it can be used in those who are concerned about their gaining weight or currently overweight. It can be used, and 1 to 3 milligram per kg per day may be the best dosage. Again, we have studied another prospective study of topiramate versus propranolol in the prophylactic treatment of migraine by Jasita Jairaj and Remini. Here we can see that the relief after treatment with the propranolol and topiramate also almost equal efficacy was seen. And again, you can see that the propranolol group side effects were also almost equal with propranolol and topiramate. So that means all the drug has its own merit, and depending upon the child's category. For example, one is obese, you may go for a topiramate. If thin, and we can go for a sodium valproate or a flunarizine, like that. So these are the drugs used for prophylaxis. Propranolol 1 to 4 milligram per kg, and again we use amitriptyline also as a drug for the prophylaxis. Then valproic acid, topiramate, again see the 1.5 to 3 milligram. Sodium valproate usually I give 20 to 20 milligram per kg. Even though cyproheptadine is included here, nowadays we don't use cyproheptadine for them because we have better drugs for the management. So after these two, don't forget about the biobehavioral therapy, because healthy habits, 5-bit techniques, and the management of comorbidities. Because in that management of the comorbidities as well as the triggers is very, very important, like having a good night's sleep. Because nowadays, because of the lockdown, but I find that children are sleeping very, very late and waking up very late. So that is a very big issue. That means sleep well, and regular eating is also very, very important. Okay, and then continuous TV viewing nowadays, and just how long have you been watching cartoons? All my life. So this is what is happening nowadays, and I'm seeing a lot of eye-related problems also because of that. And again, you have to reduce other triggers, like say prolonged school bus journey is a problem. Now a school is not there. When the school is there, you would notice that even though the school is just half a kilometer away, the child may be traveling 2 hours in the school bus. So that may be one issue. And especially in adolescents, certain inebriations in young children, ice creams or chocolates may be a triggering factor. And family issues also will be a triggering factor. So this also things, a caring mother, and lingering fear of stick always there. So a caring mother, a caring teacher is more important. And definitely comorbidities like depression is there in children also. So it has been young children as well as adolescents. This has to be treated in a proper manner. And then, as I have mentioned, cyclical omitting, the drug of choice is amitriptyline, because you go for amitriptyline and you will get a very good improvement. There are, I won't be going to the other newer modalities of treatment, because They are not being tried in children like a CGRP receptor antagonist. Many are there, or some people have or surgical methods or neuromodulation, the hypothalamus, or anticonvulsants are used as a drug for migraine. And it is said that obesity in childhood linked to later migraine. That means again, that again is a good indicator for a good lifestyle. So to conclude, our take-home message is that we have understood the headache in 3 steps by doing a comprehensive headache evaluation, understanding the seizure headache types, going for the treatment. All in 3 modalities I have described: primary headaches, migraine, tension type of headache, and trigeminal autonomic cephalalgia. And so recognition and treatment of migraine pediatrics is important given the high prevalence and associated disability, more likely to be bilateral and shorter. However, other features are shared, including premonitory and cranial autonomic symptoms. The episodic migraine syndromes often present in that means migraine variant syndromes also can be there, like benign paroxysmal vertigo. And as I have mentioned, benign paroxysmal torticollis is associated with genetic variants seen in hemiplegic migraine. And triptans have been shown to be effective for acute treatment of migraine in children and adolescents. And preventive treatment in this group includes medication, behavioral treatment, and lifestyle management. So with supportive treatment, supportive doctor, supportive parents, and a teacher, our outcome is a child who can fare well in the school. Thank you.
Thank you, sir, for your excellent presentation. We have some audience questions. So I will ask you those questions one by one. I hope I'm audible.
Yes.
Okay. The first question is from Dr. Hussain from Malappuram. He wants to know whether there is any association between sinusitis and migraine in children.
As I have mentioned, because many times parents think that there is sinusitis and migraine. But sometimes I have seen that certain allergies, because a child who is sneezing persistently can trigger the headache. But otherwise, first of all, you must understand that sinusitis per se itself is very much less in children. That is one point. And when we ask for an MRI, MRI people give a diagnosis of sinusitis by finding some opacities in the maxillary sinus or a frontal sinus like that. But as I have mentioned, there must be a definitive discharge, nasal discharge, the sinus tenderness, etc. must be there. But again, we don't know. There are a lot of triggers for a migraine, and sometimes because a child who had this sort of sinusitis or a can have a continuous migraine also, because number of times we have seen a viral fever, child recovers from the viral fever, and then she continues to have a headache. So I usually call it a viral fever-induced migraine. This sort of things can happen.
Right. Thank you, sir. The next question is from Dr. Nana Bau from Mumbai. His question is, could pain in abdomen be the symptom of a migraine patient?
Definitely, I told you, but the thing is, sometimes, especially abdominal migraine without headache and developing syncope, I have seen number of times. But only thing is that here again, you just go to the IHS criteria. They are giving the correct criteria for making a diagnosis. And most important point is, even for the migraine as well as other things, you have to exclude an organic causes. Then only you go for a diagnosis of abdominal migraine. That's all.
Yeah. Thank you, sir. The next question is from Dr. Indu Kaladar from Hyderabad. He wants to know how to differentiate between abdominal migraine and migraine with aura. I think this is on similar lines.
Okay. So usually the abdominal, the aura symptoms we consider as either a visual symptoms or a somatic symptoms like paresthesia, etc. But in neurological parlor, for example, the gurgling sound or a feeling of something coming. All these are considered as an aura symptoms in a seizure. But abdominal symptoms cannot be considered as an aura symptom for a migraine. But migraine usually get a visual aura or a neurological symptoms. They are the manifestations of aura.
Yeah, thank you, sir. The next question is from Dr. Shrikanta Rao from Bangalore. The question is, how does cyclical vomiting syndrome present? Is it self-limiting and how to manage?
In just like migraine, it can be self-limiting. But what I have, don't live like that, because many times it may be devastating, and these children can have even at least sometimes people may operate the patient also for acute appendicitis or other acute abdominal problem because of the persistent. I have seen, I have treated children also, because those who have been operated for so-called appendicitis or because of the persistent vomiting. And when the ultrasound is done, there will be a probe tenderness. So that diagnosis will come. But only thing is that after the operation, they find that appendix is not inflamed, and then they make a diagnosis. So, moreover, this may be a problem continuing to their pregnancy also. I have seen, because I have treated girls from their young age. They continued to come to me, and they get married. At that time also, because one girl was reluctant to reduce the drug. They told you amitriptyline is the drug of choice. Don't give antiemetics. Maybe at the time of acute attacks, we can give domperidone as well as IV fluid. But otherwise, the best drug for the treatment of cyclical vomiting is amitriptyline. You give continuous as a prophylaxis. And I asked her to stop when she was pregnant, but she was even continuing that, because when she stopped it, she developed a severe vomiting of pregnancy itself. So that means you have to identify, you have to treat it properly.
Right. There is one more question from Dr. Shrikanta Rao. He wants to know, in young children who are obese, what should be the prophylactic of choice, because there is a risk of weight gain with certain drugs?
Yes, in that case, I think you can start with topiramate is the best drug of choice in that situation. Just 1 milligram per kg. Being obese, the dose may be high. So 1 milligram per kg will be sufficient. But some situations I use propranolol. But again, I have seen a weight gain with propranolol also. If she doesn't have or he doesn't have asthma, then you can use propranolol also. But sodium valproate and flunarizine may not be appropriate for an obese child.
Yeah, thank you, sir. This is the last question. This is from Dr. Ahmed from Hyderabad. He wants to know how to manage a case of headache and vertigo together in a child.
Yes. A vertiginous migraine is a very common situation. Here again, what I do is I usually give the combination of prophylaxis, that either a propranolol with amitriptyline or a flunarizine with amitriptyline as a prophylaxis. And I advise them to take, depending upon the attacks. If there is vertiginous symptoms, at the time of attack, they can use beta-histine. Beta-histine is the preferred drug. And because depending upon the age, for older children, for example, a 12-year-old or a 15-year-old child, definitely you may have to give 16 milligram of beta-histine. Then only the vertigo will come down. For younger children, 8 milligram half tablet also will be sufficient. So at the time of attack, you can advise it. And if they are getting headache attacks, usually in such situations, I prefer a combination of paracetamol with domperidone or sometimes paracetamol with the prochlorperazine, because the mouth dissolving tablets are available. So that will be useful. Prochlorperazine also will be useful in the management of vertiginous headache.
Thank you, sir. So that was the last question. Thanks a lot for your presence.
I think I can't hear.
Can you hear me now? Can you hear me now? Can you hear?
Dr. Kenny, I think doctor has some issue.
Sorry, I can't hear. I think
Okay.
somehow there is some problem with the
Okay.
sound.
Yeah. So no
Can
issue.
you hear there? Can you
Yes,
hear?
yes. We can hear.
Yes, but
We
I
can hear.
can't.
Okay.
Shall I
No
just
issue.
leave and come back?
Yeah. No issue, sir. We are done with the questions. So I would request Mr. Jose Kutti to give the vote of thanks because as there are no further questions on this.
Uh,
So can you hear us now?
now you answer. You answer there. You ask question again.
So can you hear us now? Can you hear us? Can you hear us? Okay, fine.
Okay,
Jose
thank you.
Kutti, I
Thank
would
you.
request you to give the vote of thanks because we are done with the
Yes,
questions.
yes.
Sir,
Yeah.
is it audible?
It is not audible to sir. You can give the vote of thanks to the.
Yeah.
Yeah, respected doctors, it is my pleasure to and privilege to propose an vote of thanks on this occasion. On behalf of Johnson & Johnson, Janssen Pharmaceuticals, we extend our sincere thanks to our honorable speaker, Professor Dr. Mohammad Kunju, who blessed the event with his presence and enlightened the delegates with his excellent presentations on pediatric migraine. Thank you very much, sir. Also, our sincere thanks to all the delegates from across India who really attended this event, especially in this pandemic situation. Our sincere thanks to all the delegates across India. Also, my sincere thanks to all my colleagues from across India. They really worked many days for arranging this program. Thank you very much. And also, I am thankful to the technical support people. Thank you very much. Thank you.
So thank you, everyone. I think with this, we have come to the end of this session. And I'm sure this session must have helped us to understand a little bit more on the pediatric migraine. What about the concepts and controversies are there? So thank you, everyone, once again. I request if anybody has any question, they can just give the question to the respective areas representative. And we will be in touch with Dr. Kunju and we will address them also in future. So thank you very much, everyone. And with this, we will drop the meeting. Thank you, Dr. Kunju. Thank you, everyone. Dr. Kenny, thank you to you also.
Thank you. Thank you.
Okay, bye-bye. Thank you, sir. Thank you, Dr. Kunju. I don't know whether you could hear us or not. Thank you.
Thank you.
I'm ending now, sir.
Okay.